Hi everyone, welcome to our webinar. We're going to go ahead and get started. Introduce Nick Staub, our medical director, and he's going to go ahead and give the webinar.
Good afternoon, everyone. Thank you for joining us today for the Arizona COVID-19 response webinar for healthcare facilities. My name is Nick Staub. I'm the medical director for the Bureau of Epidemiology and Disease Control here at Arizona Department of Health Services. So our plan for today is to give a brief review of the outbreak to date, including the response here in Arizona. We'd like to go over how you can prepare, what you can do, and at the end we will have an opportunity to go over some questions that you put in the chat box on WebEx. In addition, we have questions that have been submitted ahead of time in the last couple of days that we can go to as well. Again, if you have a question, we ask you to use the chat box feature, and we will try to address as many questions at the end of the webinar as we can. So just to review the outbreak to date, so in December 2019, towards the end of December, China first reported cases of pneumonia with unknown cause. Initially, these cases were linked to a seafood and wet animal wholesale market in Wuhan, Hubei province, China. And initial reports suggested that there was animal-to-person spread associated with this market. In January, the cause was identified as a new coronavirus or novel coronavirus. By the end of January, there were over 9,000 cases globally. Here in the US, airport screening was initiated, and the first case of novel coronavirus was detected in the US in the state of Washington on January 21st. Arizona confirmed its first case on January 26th. In February, the WHO officially named the disease caused by the virus known as SARS-CoV-2 and described the disease as COVID-19. By the end of February, there are 51 countries with cases, and over 80,000 cases total were reported. The US had its first possible case of community spread of COVID-19 in February. This is a map provided by the World Health Organization that shows the current distribution of COVID-19 cases reported around the world. And as is demonstrated here, it is on all continents throughout the world. So what do we know about COVID-19? COVID-19 is caused by a novel coronavirus named SARS-CoV-2. Coronaviruses are a large family of viruses. There are several known coronaviruses that circulate in the population and infect people, usually causing mild respiratory disease, such as the common cold. Coronaviruses can be found in animals, and some of these viruses have the capability of transmitting between animals and humans. They have also been known to have person-to-person spread. Infections with coronaviruses can have a wide range of symptoms from very mild to severe. Symptoms can include fever, cough, and difficulty breathing. These symptoms can look very similar to many other viral respiratory infections, especially that transmit at this time of year, including seasonal influenza. Information so far suggests that most COVID-19 illnesses are mild. A report from China suggests serious illness occurs in about 16% of cases. And older people and people with underlying health conditions like heart disease, lung disease, and diabetes are about twice as likely to develop serious outcomes versus otherwise younger, healthier. The virus is thought to spread now by person to person via respiratory droplets that are produced when somebody coughs or sneezes. There's currently no available medication to treat or a vaccine to prevent infection with SARS-CoV-2 or the disease known as COVID-19. We at the Arizona Department of Health Services are recommending that you take everyday measures right now, including proper hand hygiene, covering your coughs and sneezes, staying home when you're sick.
This guy's just reading off.
So you may have noted that there have been a lot of changes in guidance that have been coming down from the CDC and from the state in recent days. This is in response to a change in how we're approaching this outbreak. So initially, at the beginning of an outbreak, you want to try to contain the source, contain the virus at the source of the outbreak. So that is what was happening when we were instituting strict travel restrictions and screening at airports and performing contact tracings of known cases and instituting isolation and quarantine. Now, with increasing evidence that there is spread within the community, we're moving to a community mitigation and preparedness phase. We'll talk about how these have implications on the change in guidance. So in the early stages of an outbreak like COVID-19, public health takes measures to contain diseases and stop them from spreading in the community. In Arizona, local public health partners have been monitoring travelers returning from China for symptoms of COVID-19 and ensuring that individuals suspected of being infected were isolated until their test results came back negative. But as I said, given national updates and increasing evidence of transmission within the community in general, it has become clear that there is a high likelihood of community spread across the U.S., and public health measures have begun to shift to slow the spread of the virus rather than to contain it at the source. So, what can you do to help us? We ask that you be prepared, so stay informed about the local COVID-19 situation. We ask that you find reputable sources for information about COVID-19 and avoid spreading inaccurate information. Public health agencies are sources that will provide factual, up-to-date information. And you can visit our site at ADHS and then the CDC's website as well. Also, local health departments are may be maintaining websites that you can refer to for up-to-date information. We ask that you develop or review your facility's own emergency plan. So most healthcare facilities are required to have emergency plans. We ask that you review those, especially in terms of staff absenteeism and how you're planning to ensure staff availability as your staff members may become sick and may be excluded from work. This could include extending hours of shifts, cross-training current employees, and hiring temporary employees as available. We ask that you establish relationships with healthcare and public health partners in your community. We will give reference in multiple places in this webinar and also on our website as to where you can find contact information for your local health departments. We ask you develop preparedness plans, including how to manage patients, accepting transfers, sharing supplies, reviewing memoranda of understanding, and how to make use of your healthcare coalitions. We also ask that you review your infection prevention and control policies. As our guidance has been updated and as the outbreak of COVID-19 has changed, the policies for infection prevention and control that your facilities use for seasonal influenza and other viral upper respiratory infections will largely apply to your infection prevention and control of COVID-19. We also ask that you create an emergency contact list specific to your facility that includes local health departments so that you can make use of that resource as well. The other thing that we ask is that you communicate with staff and keep them up to date on the current understandings of the outbreak. This includes providing education and job-specific training for healthcare providers regarding COVID-19, potentials in surge in patients, your facility's own preparedness plans, and your facility's sick leave policies. We ask that you be communicating with patients. So describe what actions the facility is taking to protect them. Provide updates about changes in policies that might affect your patients, including visitation policies. and provide updates about changes in policies that would affect them. So what can you do to protect your workforce? So we're asking that healthcare facilities are screening patients and visitors for symptoms of acute respiratory illness before entering your healthcare facility. Again, we expect that these are practices that most healthcare facilities are already practicing during the respiratory illness season. We're asking that you ensure proper use of personal protection equipment. And in a few slides here, we'll review what those recommendations are for COVID-19. And then we ask that you conduct an inventory of available PPE at your healthcare facility. Local health departments are collecting information on shortages of PPE in their jurisdictions. This is helping guide those facilities and those practices that are experiencing shortages. We also encourage that sick employees stay home from the healthcare setting. So again, this is a good opportunity to review your absentee policies and your sick policies to make sure that employees who are ill know that they should stay home and are encouraged to do so. In terms of protecting your patients, we want you, again, to stay up to date with guidance on ways to manage patients with COVID-19. We ask you triage and cohort patients with respiratory symptoms in waiting rooms. So identify a well-ventilated area where patients and visitors with respiratory symptoms can be placed and wait for care. Ideally, this would allow patients to be at least 6 feet apart, which defines close contact for infections such as COVID-19. Supply visual alerts such as signs and posters at entrances and in strategic places to provide instruction on hand hygiene, respiratory hygiene, cough etiquette. Ensure supplies are available, including tissues, waste receptacles, and hand sanitizer. And provide face masks to be available at triage for patients who are exhibiting respiratory symptoms. And then specific considerations for inpatient facilities. We ask that inpatient facilities now start to think about what it might look like to reschedule elective surgeries and diagnostic procedures as necessary, as this may free up space in your facilities for those who are acutely ill, requiring hospitalization with COVID-19. We ask that you think about limiting visitors to COVID-19 patients, again, in order to further mitigate the spread of disease within the community. We ask you to plan for surge of critically ill patients and identify additional spaces to care for critically ill patients. And again, I believe most of these should be part of your plans that are already in place as to how to deal with surges in regular seasonal influenza. Considerations for outpatient facilities would be to consider rescheduling non-urgent outpatient visits as necessary. Consider reaching out to patients who might be a higher risk of COVID-19 related complications. Consider accelerating the timing of high priority screening and intervention needs for the short term. And for symptomatic patients who need to be seen in a clinical setting, should be asked to call before they leave home in order that you can put into place isolation procedures to isolate those patients as soon as possible in order to protect other patients and healthcare workers in your facility. And back a few bullets here when considering reaching out to patients who might be a higher risk of COVID-19 complications. Again, we would consider those patients to be the elderly, those with medical comorbidities, and potentially other persons who are at higher risk of complications from respiratory disease, such as pregnant women and patients with immunodeficiency. And then also consider eliminating patient penalties for cancellations and missed appointments related to respiratory illness, again, in an effort to encourage that those patients with acute symptoms are not entering your healthcare facility if they don't need to. So infection control. Infection control in the healthcare setting, we changed our guidance about a little over a week ago. Current recommendations are for standard contact and droplet precautions with eye protection, so either using a face shield or goggles. Hand hygiene, so again, going back to the basics of infection control and really encouraging hand hygiene and making sure that hand hygiene is sufficient. Wearing appropriate PPE to comply with the precautions that are recommended, including gloves, gown, medical masks, and eye protection. And then airborne isolation room is still recommended for any aerosol generating procedure. These procedures can include intubation, extubation, CPR, cardiopulmonary resuscitation, and bronchoscopy. Use of a respirator and airborne precautions for these aerosol generating procedures are recommended if an airborne isolation room is not available. Furthermore, for an infection control, have a plan to manage visitor access and movement within the facility, again, consistent with your plans for seasonal influenza. Monitor and manage ill and exposed healthcare personnel. At the end of this slide set, we'll give you the latest update on our recommendations for that. Train and educate healthcare personnel, as we've mentioned before. And then in terms of environmental cleaning, we've gotten a lot of questions around what is recommended for any particular recommendations for environmental cleaning for SARS-CoV-2. Considerations should be made to dedicate medical equipment as your facility is able to individual patients. Follow environmental cleaning and disinfection procedures as routine. At this time, there are no extraordinary recommendations other than those already used for other respiratory infections. For bleach and water solutions used for disinfection, it's recommended that you use a 0.1% solution at a 1 to 50 dilution. And then recently, EPA has updated their list of registered antimicrobial products for use against SARS-CoV-2 or COVID-19. And we have a link here. It's a very extensive link, and we are hopeful that many facilities will find that the products they are already using are on this list already. I told you I would talk about risk assessment for exposed healthcare personnel. So as of March 4th, the previous recommendations of risk assessment were impractical for implementation by healthcare facilities, namely because we are seeing increased evidence of community transmission, and all healthcare workers are at some risk for exposure to COVID-19, whether in the workplace or out in the community. So we're recommending that facilities shift their emphasis to more routine practices, which include asking healthcare workers to report recognized exposures, regularly monitor themselves for fever and symptoms of respiratory infection, and again, to not report to work if exhibiting ill symptoms. Facilities should develop a plan for how they will screen for symptoms and evaluate healthcare workers. One suggestion is to have healthcare workers report absence of fever and symptoms prior to starting work each day or shift. For healthcare workers with known exposure to COVID-19 patients or suspect COVID-19 patients, the decision to quarantine or exclude those healthcare workers from work should be a decision made in consultation with the local public health authority. We have additional resources linked here that we will post this webinar, these slides, to our website. So all these links will be available as hyperlinks. If you have any questions about how to prepare for COVID-19, please contact your local health department If you hyperlink here, you'll get the contact information for your local health department. And again, our websites are available as resources to answer other questions you may have. So at this time, we will go to our chat box, see what kinds of questions have been placed there and answer them in order. And then we also have, like I said, the questions that you had submitted earlier in the week for reference as well. So there's a question about what recommendations we have for home isolation for special populations, including homeless, long-term care, and those in skilled nursing facilities. Again, for long-term care and skilled nursing facilities, I recommend that you go to your plans for seasonal influenza and refer to those as to how you would isolate a patient with known flu. The question about and again, the questions about isolation and quarantine as we make this pivot from containment to mitigation are going to become, there's going to be increasing guidance. We're not going to be sticking to a strict 14-day quarantine period, and isolation will really be more of a social distancing and recommendations as to how to avoid spreading disease, much more similar to seasonal influenza. So stay tuned for that guidance.
Question on how law enforcement can be tested if exposure is suspected. If you're going through your county health department, that will depend and also depend on the risk assessment. If you're going through a commercial lab, it just depends on the normal processes to get those specimens collected and sent off and tested.
The question about the national stockpile and the timeline that we should expect for receiving supplies. The Department of Health Services currently does not know what the contents of the stockpile are, nor we would be receiving the supplies. But we will continue to recommend that at this point we can work with your local health department and let them know what your needs are, so that you can maintain an inventory of what the resource needs are in your zone.
And just to stress, the local health departments do not have any caches of supplies at this time.
There's a good question here that we've been getting, which is why has there been a change in isolation requirements, but CDC is the same. So this is in reference to our recommendation to go to a droplet precaution, and CDC still maintains airborne precautions. So our decision to go to droplet precautions was based on guidance that is consistent with the World Health Organization that they have maintained since the beginning of this outbreak. It is consistent with the precautions given to other human coronaviruses. And so we feel like at this time, as we're making this pivot to changing the way we're dealing with infections, that it is prudent to use droplet isolation. There's a question about recommendations for testing and should it be done at an outpatient clinic or centrally. So currently, as of today, testing is available through the Arizona State Public Health Laboratory, and the decision to be tested there is in consultation between a physician, the local health department, and the state health department. As more labs come online providing commercial testing, then any provider in the community can work directly with that commercial provider to arrange testing. But at this point, we can test in both an outpatient and an inpatient setting. Again, these are just changing recommendations on a fairly fast pace as our ability to test is rapidly increasing.
And you would have to work with a specific commercial laboratory to find out their testing requirements, as they may not have the ability to do those collections at their kind of central centers for other testing.
There's a question regarding what steps are the current ERs taking to keep potential exposed patients from other patients waiting to be seen in for other healthcare needs. As mentioned earlier, each healthcare institution is required to have an emergency preparedness plan to deal with different types of emergent situations, including infectious disease and infection control. So the steps that a ER is taking may differ from site to site in following their own policies and procedures to protect the clients they are serving.
There's a clarification question that's important, just checking that standard surgical masks are okay. And yes, with our change in guidance from airborne to droplet precautions, the recommendation would be to use a standard surgical or medical mask instead of the N95. The N95 would still be recommended for those aerosol generating procedures such as intubation, extubation, and bronchoscopy. There's a question about requesting for a viral panel prior to testing. I didn't review our current guidelines for testing at the Arizona State Public Health Laboratory in this webinar because I believe things will rapidly be changing as commercial testing is available. But currently our ability by pure numbers to test people at the state lab far exceeds what we expect to be the need once we broaden the availability of testing. So we have been using the comprehensive viral panel, PCR panel, and flu testing as a way to triage those patients that we have the ability to test for COVID-19 at the state lab. Again, that is no longer a requirement once physicians are requesting testing through a commercial laboratory. There's a question related to how long are droplets, are infectious droplets on surfaces. Again, we don't have all of that data for this particular virus. We can extrapolate what we know based on other human coronaviruses, and that is anywhere from a couple hours, 6 hours to 2 days. So again, we don't know exactly, but the recommendations for cleaning and following routine cleaning practices, we believe are sufficient to take care of that concern. There's a question about thresholds of public outbreak or positive employee tests in order for an office to shut down. We talked kind of about steps that you can take now in order to ensure continuity of your office staff. Again, things like cross-training and relative ability of people to come into work, extend their hours. And again, this is another important role in making sure that your employees who are exhibiting ill symptoms are staying away from work so that they are protecting their fellow employees from getting sick. The decision, we don't have a threshold in terms of a number. It's really based on your ability to continue to provide care at your facility with the staff you have on hand. So there's a question about recommendation for facilities screening their healthcare workers. So as I mentioned, one example was asking healthcare workers to self-report that they are afebrile and not experiencing symptoms before they start working. So that's one suggestion. There's no guidance that we are giving now in terms of screening for fever or other symptoms through kind of a centralized mechanism. Again, I think this goes back to what should be your standard operating procedure during the respiratory viral season and how you exclude healthcare workers who are exhibiting acute ill symptoms.
So we have a question about turnaround time for COVID testing. So with our Arizona State Public Health Laboratory, it's been about a day or two to get testing turned around, and then we send those positives on to CDC for confirmatory testing. And then it sounds like some of the commercial laboratories have put in their press release that it will take up to a few days to get results back.
There's a question about, do travel layovers in the countries listed as level 3 and 2 count as part of the decision to send the patients meeting the criteria to the ER? So the only criteria for sending a patient to the ER is based on their clinical appearance. So if you're concerned that a patient is ill enough that they require some urgent intervention or hospitalization, those are the only reasons to send to the ER. Currently, travelers to those higher risk areas are being advised upon return to self-quarantine and to watch for symptoms in their home. So even if they have symptoms, if those symptoms don't require that they present to the ER, the current recommendations are to quarantine or isolate at home. And again, keep in mind that as we are quickly kind of making this transition from containment to mitigation, the recommendations for isolation and quarantine will be changing in the coming days. So this webinar is being recorded, so the presentation and the answers to these questions will be available on our website. So look for that being posted in the coming days.
There's a question on specific swabs to use, and the same one using the screen for flu. So it should be similar to the ones you're using for flu, the synthetic swabs.
The standard nasopharyngeal swab, and then it will be transported in a standard liquid viral media. So there's nothing extraordinary about the swab and its and how it's being submitted. Again, as commercial laboratories come on board, they may have different recommendations for specimen collection and transport than what we have been using for the state health lab. So we recommend that you stay alert to those recommendations as those labs announce them. We are just looking through some of the questions that have been submitted ahead of time and trying to find good. They're all good, but ones that we haven't already answered. There's a question here about how does COVID-19 compare to seasonal influenza? Again, as we collect more information about SARS-CoV-2 or COVID-19, as we expect that there are a large number of mild and even some asymptomatic cases, we know that the denominator, the total number of infected patients, is likely to grow quite significantly. That's going to have a significant impact on the case fatality rates that have been reported up to this time. A lot of our data at this point, as you've seen that come out of the United States and China before us, is showing kind of what's going on in the very severely ill. So we know that we're capturing kind of a more severe picture of COVID-19 than what we think it will truly be down the road. So it's hard to compare those numbers to flu right now. One thing to keep in mind, we are still recommending influenza vaccination at this point in time because we are still seeing a significant amount of influenza circulating in the community. And there's also prescribed treatment available for influenza. So both treatment and vaccination for flu make it a likely easier to control infection than SARS-CoV-2.
We do recognize that we have healthcare institutions that provide in-home care and services such as home health and hospice. And as they go into those home environments, they need to protect themselves if they are encountering any clients with these signs and symptoms, as Dr. Nick alluded to. And again, be cautious of your infection control practices that you've established through your personnel policies and procedures.
So there's questions about if there's any immunity built up from confirmed infections. As Nick has said before, that we're learning more about the virus every day and the infection. So we don't know at this time, but we're hoping we get some answers on that question soon. And I think it looks like that's all for the questions at this point, and we appreciate everyone being on the webinar. Thank you, Dr. Nick, for presenting. And again, we'll try to do our best to address the questions through our website and FAQs. Thank you so much for your time.